So welcome back. My name's Deepak Joshi. I contacted Martine and Maxine about a year ago, and then I spoke with Doug, who I know very well, and we tried to put this together. So this has been about a year planning. We didn't build this place especially for it, but it is a very nice venue. I hope you agree. So I'm very excited to have this here, and it's hopefully something we can do on a yearly basis together, maybe more, who knows. So I've been asked to talk about ERCP, and a lot of you in the room will have had an ERCP. There may be some of you who've never had an ERCP, so we can talk through some of the sort of concepts before, during, and even after. So I will talk about the basic anatomy, and I know John has already covered some of these topics. I am going to cover the what, the when, the why, and the how. And like I said, talk about, it's not just the procedure itself, it's the sort of the investigations before, the care before, and then the care afterwards as well, immediately post-procedure, and then when you're discharged as well. So I play everything by the book. These are my disclosures. So if I'm accused of, pimping one particular company or not. And then these are my other disclosures. So I am a devout Aston Villa fan, and you can tell by my accent I am from Birmingham. And I actually love the colour yellow, and I'll show you a picture. So anyway, so I want everybody to stand up, please. So everybody stand up. So I've opened my heart to you. I've told you a bit about myself, not a lot. But this is how I get to know you. And what I'll do is I'll put up certain there'll be different sort of sentences that go up. And as you feel more uncomfortable, or maybe it doesn't apply to you, sit down, okay? I hope that will make sense. Ooh, dimming the lights as well. The music will start very shortly as well. So attending today, hopefully everybody's happy attending today, yeah? And, oh, wow, okay. Okay. What about getting the tube in London? Yeah, you okay with that? Yeah. Maybe, I know there've been delays today, so maybe that's not so poignant. What about having a blood test? Everybody still okay? Yeah? Okay, all right, okay. What about having a liver biopsy? Okay. All right. Okay, yeah. So we see who's standing at the end, last man, last woman. Okay. And then what about having an ERCP? Maybe I should say having an ERCP by Doug or something. So, okay. And then everybody should lie down because one of these lovely people may be leading this country. And if you watched the debate last night, I'm a bit worried. Okay. Anyway, so it's just a good way of understanding who the audience are. Okay. So a bit about the anatomy and the sort of physiology of the liver. And like I said, I know John has covered a lot of this. But it is just worth going over this once more. There are essentially two lobes of the liver, the right or the left, and the right is the biggest lobe. And within that, you have different vascular structures, and obviously we have the bile duct itself. So this is the bile duct, obviously the main duct. It goes off to the right, the left. And then you can actually divide the liver into different segments as well. So sometimes there may be reports you get back. You should all receive your letters from clinic, and it may say there may be sort of changes within your different segments. But if you do ERCP and you look after patients with biliary disease, you start seeing the bile ducts everywhere you go, okay? So this is from Marks and Spencer's, and there are other supermarkets available, all right? But you see, it's very similar. You've got the bile duct going up, you've got the gallbladder, and then within it, you've got the biliary tree. I think this is the elderflower and mint version. But anyway, maybe it's just a reflection of how I am as a person. This is my interpretation of the bile duct and the sort of pancreas and the biliary tree. And again, this is how everything's connected. So this is your pancreas here. This is your main duct. This is your main bile duct, your gallbladder. This is your main blood vessel going into your liver, the portal vein, and how it's connected to your spleen. And this is your small bowel as we go down as well. And this is my artistic impersonation of it. So this is perhaps a bit better. So you've got the main sort of muscle here, which is called the major papilla or the ampulla of Vata. And this controls the entrance to the bile duct and to the pancreas. Then you have your common bile duct, the cystic duct, which drains your gallbladder. And then you start getting into the liver. You've got your sort of right and your left and then obviously that sits within your liver itself. So if you do go on to have an ERCP, or if you've had an MRI, these are some of the things they will describe: the main duct and the bile ducts within the liver, and how it's sort of affecting potentially the pancreas as well. So ERCP, it's a long sort of, it's a very good acronym, because actually when you write it out, it's quite difficult, but it stands for endoscopic retrograde cholangio relates to your bile ducts, and pancreatography relates to your pancreas. So how do we do it? We use something called a duodenoscope, which has been referred to as the black snake, okay? All right, it's not as, this black snake is not as long as the colonoscope, okay? But it's very similar, and all endoscopy actually, the handles and the sort of the way it's made up is exactly the same. So it's a left-handed, you control it with your left hand. So in theory, people who are left-handed are better endoscopists. I'm not left-handed. Are you left-handed? Oh, well, Doug is, okay. All right. Michael, are you left-handed?
I played the violin, so I'm left-handed.
Well, it's just me then, isn't it? Okay. But the other major difference is that the camera is on the side of the scope, because, and I'll show you a video, when we're trying to get into the bile duct, we will sit sort of en face. So if the camera was at the end, like in the colonoscope or the gastroscope, you'd probably just see past it. And the other major difference is that you have something called a bridge, or if in the US it's called an elevator. And what it does, it just allows you different ways of accessing the bile duct and sort of getting a different plane of movement. So this is a video. I hope there's no blood. I showed this to my son this morning, who's 8. And he said, I hope there's no blood. And I said, no, I don't show them to anyone if they go badly. But this is the major papilla here. This is sort of the duodenum up here. And if this works, you'll be able to see. Let's see, there we go. Okay, so this is the sphincterotomy. This is the cannula we're using. And we're aiming for this little orifice here. And everything is magnified. So this is, if you had an ERCP, this is what's happened to you. I'll show that once more. It's worth seeing. One of the problems sometimes with patients with PSC who have an ERCP is that this muscle here, the opening, can be actually very small. And sometimes, again, Mark said his ERCP took an hour. I'm not surprised, because it is a little bit trickier. All right. So ERCP, and John has alluded to this, it's no longer a diagnostic procedure. So before you have an ERCP, and we'll come to this, you should have had a series of tests, blood tests, usually an MRI scan, before you go on to have an ERCP. And it is definitely more therapeutic. It is complex, certainly if you're dealing with strictures within the liver. They can take a long time. You have to use different wires, and I'll talk you through some of those things now. And like I said, it is tricky. The muscle can be quite small. You have to take your time. You don't want it to be rushed. And we'll talk about a little bit how you're sedated for this procedure as well. So in terms of when and why do you need an ERCP, usually you've had a change in your symptoms, or you've had a change in your liver blood test. So when you come to clinic, we should be asking, not just asking, oh, how are you, and then everything's fine and we carry on, but specific questions. What about itch? Is it new? Is it increasing in severity? What about pain? Somebody asked about sort of pain within their liver. Could that be a sort of sign or a sort of a suggestion of cholangitis? Have you actually had frank cholangitis, frank infection, sepsis? You've been in hospital. So see, these are some of the things which may precipitate an ERCP. But before that, most of you, in fact all of you, will have had some sort of imaging. So what we tend to do is an MRI scan. If you can't have an MRI scan, it could be due to claustrophobia, could be that you've got metalwork, usually it's a pacemaker, then you probably should have a CT scan. And what we're looking for is changes within the bile duct. So ERCP, when we teach sort of ERCP to sort of junior members of faculty, we talk about, thinking about, before the patient comes into the room, you already know what you're going to do. So if there's a gallstone, you know you're going to take it out. If there's a narrowing in the duct, a stricture, you know you're going to stretch that, or you're going to assess that stricture. So it's not, you come into the room, we inject a bit of contrast and go, oh, look, there's a gallstone or something like that. So it's definitely premeditated. We know what we want to do. There will be cases sometimes where things change, and during the procedure we may need to sort of think a little bit on our feet. So only after then do we think, is there an indication for ERCP? Okay. So, okay. So in terms of indications for ERCP, I would say these are the two main indications for ERCP, and this is sort of deliberately in grey. It is deliberately a bit smaller. So a lot of the time we will do ERCP if there is a new narrowing, a stricture, and John talked about a dominant stricture. There's a lot of debate amongst people who do ERCP, who look after patients with the PSC, what a dominant stricture is, so it's not worth going into that. But, you know, by and large, and the way I see it, it's a new narrowing in the bile duct which may be causing or adding to your symptoms. And that is by and large the commonest indication for ERCP. At the same time, you might develop gallstones. We know the flow of bile in patients with PSC that, you know, is reduced, so you're more likely to get stasis, and like any free-flowing sort of river or delta, you know, you can cause gallstones, and that can lead to symptoms like a rise in your blood test, itch, or cholangitis. And this is a very common finding. Very rarely we do ERCP to insert tubes into the bile duct and then deliver it through your nose to divert the bile, but I don't think it's worth sort of mentioning that. And it's quite rare to do that these days. So this is an ERCP of a patient who has got a biliary stricture, a biliary narrowing. And what you can see here is this is the main bile duct going up here. This is going off to the right. This is going off to the left. And hopefully you can appreciate there's a loss of contrast here where the arrow is. And that is a stricture. And I'll come on to as to how we can potentially treat that. Just out of interest, who has had an ERCP in this room? Okay. So one of the things, if you've got gallstones, and the way we treat gallstones in patients with PSC is by and large the same as anybody else with gallstones. So what we have to do sometimes is a little cut at the bottom of the bile duct, and this is called a sphincterotomy. And again, there is a video which will show us doing a cut. So you can see there's a wire here on the end of your sphincterotome, and we've made a little cut here. I might repeat the video again. And that's what a sphincterotomy is. You can see the cutting. So we cut and we sort of coagulate at the same time. And the whole point of that is that there will be sort of microscopic blood vessels there. So we're not sort of just cutting through and causing bleeding, and we're sort of coagulating as well a little bit. So those of you who've had an ERCP and never wondered what a sphincterotomy looks like, that's one in progress just there. And the reasons we may do a sphincterotomy if you don't have gallstones is if we need to put stents in, then it just makes it a lot easier to pass the stent through sometimes a very small hole. So in terms of gallstones, again, this is an ERCP. This is the patient's spine. This is the scope. And here you can see these filling defects here. And this is what gallstones can look like. Now, this is not an ERCP in a patient with PSC, but just somebody who happened to develop gallstones. So we've already mentioned that there are sort of UK-based guidelines, and Doug was one of the authors on this, which was published earlier. Martine and Maxine, PSC Support, have also helped with the formulation of these guidelines. And I think the key thing is, or one of the key messages of these guidelines was that anybody with PSC undergoing ERCP, it should really be undertaken as part of a multidisciplinary sort of group discussion. So, you know, everybody agrees this is the best thing for the patient, for yourselves. And although they don't really allude to patient sort of the ERCP being undertaken by somebody with enough experience, you know, because it is a little bit harder, it should be, you know, somebody who feels confident that they are going to be able to treat and manage the sort of, you know, the stricture or the sort of problem in front of them. So in terms of having your ERCP before, and again, you know, I really want to emphasize the importance of before you go into the room, you'll have had the MRI or the CT scan. In terms of simple things for yourself, you need to be nil by mouth. Pregnancy test is always mandated. We use X-ray during the machine, and they will always check, the radiographers will always check. And then one of the issues can be, should this be done as a day case? Do you come in the morning or the afternoon and discharge later that day? Or do you need to stay overnight? Now, that will depend on your local endoscopy service and how they deliver it. And again, also, there's one of the issues is how far you need to travel as well, and is it safe for you to go back? You'll have had your blood tests, you'll have had your full blood count to make sure it's safe to have it, you would have checked your clotting, and then for those of you or some people who are on anticoagulants, they may need to be stopped as well. I'll come to consent in a second. So I think it is very long-winded to write out endoscopic retrograde cholangiopancreatography, but that is something that we do. It's certainly something I do. For those of you who've had an ERCP, were you given either suppository of a non-steroidal anti-inflammatory medication? Put your hands up if you did, or an IV version. Okay, practice does vary. The reason we give this is to help reduce the risk of pancreatitis. Depends obviously on renal function, if you're asthmatic, have you had an allergic reaction? But again, these are all important aspects as part of your care and the consent process. We should write what the indication is. So if we're going in to remove a gallstone, we should write that. It shouldn't just be treat and continue. And we should go through the risks as well. So bleeding, anything in the body, I will say there's a risk of bleeding. But overall, unless your blood tests are very deranged, the risk of bleeding is very low. We should talk about perforation or a tear, either in the bowel, because we have to get to where the bile ducts drain out, or in the bile duct itself. We should talk about pancreatitis. And again, it depends on the individual performing. They may quote the institutional risk of pancreatitis or their personal sort of data. Infection, and I'll come to why that's important very shortly. And then there's the risk of sedation itself. The other way of sort of reducing the risk of pancreatitis is making sure you're well hydrated. If you've travelled from far, usually you're nil by mouth, you may not sort of drink anything on the way. Or if you're in hospital, we tend to like to starve most of our patients all the time and then wonder why they've lost weight. But we should rehydrate them. And there's good evidence now of giving fluid before, certainly during and after, helps reduce the risk of pancreatitis as well. So in terms of making you sleepy for the procedure, there's different ways we can do it. You could listen to me with the lights down low, and that could probably send you to sleep. Or we could actually use some drugs. So we can use intravenous sedation. We can use enhanced sedation. So this is using the drug propofol, which was made famous by Michael Jackson and Prince and other sort of rock stars from the 80s, unfortunately, who used too much of it. But it is essentially an anesthetic drug, which in the UK is only delivered by an anaesthetist. But essentially, you won't remember the procedure, and essentially you are out. Or there's general anesthetic, where you are sometimes paralyzed for the procedure, and you have a tube which goes into your lungs, which breathes for you, and you go onto a ventilator. So at King's, we are very lucky. We do all our ERCP under general anaesthetic, and Professor Heenan Michael, who's here, who was our clinical director up until recently, he's probably one of the sort of drivers for that. It makes my job a lot easier because you are asleep, you are pain-free, you are relaxed. Added to that, the nurses in the room are much more relaxed, and most importantly, you're not in any discomfort. We do it on your back. So you come into the room, you're anaesthetized, and then we move you across, and then you are asleep for the procedure. And if it takes an hour, it takes an hour. But there's no risk of you waking up, because our anaesthetists, they have plenty of Sudoku, and they keep going. We keep them entertained. We keep them well hydrated with coffee. The drugs don't run out. And it is a lot. And if it takes longer, it takes longer. So we're really lucky. We do pediatric ERCP here as well, so we go from 0 to 100. And we have dedicated anaesthetists. This is Andy Paul, who is one of our transplant anaesthetists. We have dedicated ERCPists, myself, you can see my yellow clogs. And we have endoscopy nurses who specialise in this as well. And a lot of places, and the free is exactly the same, you have sort of specialist care in ERCP. It's no longer something which somebody has, a little go at. There are specific risks, and we want to make sure this is, a procedure that experts do and is delivered at a high level, because it can make a big difference to yourself. So there's very few absolutes in life or medicine, but one of them is any patient with PSC, you should always have antibiotics, because the risk is as we go in, we inject contrast, and sometimes it may not drain as well, even though we provide therapy to those areas, and you are at risk of cholangitis. So we unfortunately can give you cholangitis. So you should have antibiotics either just before or during your ERCP, and our policy at King's is to have 2 doses of intravenous antibiotics afterwards as well, and obviously that means you will stay with us for the next sort of 23 hours as such. And these are echoed in the sort of the UK guidelines, and here these are the guidelines from the European sort of study of liver disease, and again it's an absolute, you should have antibiotics. So in terms of when we are going in for there's a potential stricture. I termed this, and Martine and Maxine saw this when we had a UK PSC meeting a couple of weeks ago, is the sort of 3 or the AAA approach. So we want to get in, and I've shown you a video already how we access the bile ducts. We want to assess the stricture, because the worry is when one forms a narrowing in the bile duct, there is a risk that there could be a potential cancer there. And we need to assess that stricture to the best of our abilities. And then we need to action. I couldn't think of, and that's why I went with a 3A, action was the only thing I could think of. But we need to then decide, are we going to just stretch that open, or are we going to potentially use a plastic or sometimes even metal stent? So there are a variety of guide wires we use, and again, you should get all of your reports, and we should write what guide wire we've used. They come in different diameters. There's different cannulas we can use, and you have your go-to wire. If anybody really cares, mine is the VisiGlide 025mm guide wire. It's a great wire, all right? Christmas is coming, so, please do think of me. And it's funny, when you meet other people who do ERCP, people all ask, what is your go-to wire? So we are a bit nerdy like that, okay? So, but it is important because there's different ways of how we can access the strictures, how we can treat the strictures, and so potentially help, improve the diagnosis or improve your symptoms. In terms of assessment, a lot of centres, all of us will do brushings. So this is quite primitive. It is a brush we open across the stricture, and a bit like a chimney sweep, we sort of push it up and down and catch the cells, and then we send it to our histopathologists, our colleagues there, to have a look to see what the cells are like. Are they abnormal? Are they reactive? Could there be a cancer there? However, brushings alone is not enough. And what we've learned is the more ways you access and you assess a stricture, the better your yield is, and better you are at making a diagnosis and potentially excluding cancer. So we can take samples as well, so we can take biopsies. We can pass very small forceps into the bile duct, and sometimes these can be sort of non-targeted, i.e. we open the biopsy forceps in the area of concern, or they can be targeted as well. And this is something called cholangioscopy, which allows us to look into the bile duct. Now, as you can imagine, the bile ducts are very small. So in PSC, where they can be sort of strictured and narrowed, you're talking about sometimes 4 millimeters, 5 millimeters, so very tiny sort of tubular structures. So technology is catching up. We now have sort of very good sort of software, cholangioscopy, which allows us to look into the bile duct. And it sounds crazy, but ERCP, the images I've shown you before, we are looking at a 2D X-ray image and trying to interpret what it looks like inside. So I do have a video of cholangioscopy, and I'll show you that very shortly. But it really has changed how the way we assess some of these strictures, these narrowings, and is real testament to technology. So this is a video. I'll just orientate you. So this is the major papilla. So they've had a previous sphincterotomy. This is a guide wire going in, and this is the cholangioscope. So it goes through our duodenoscope, where we're sitting in the small bowel, and then we pass this tube, which has got a camera on the end. And I'm hoping I will wow you with the images very shortly. So keep watching here. So this is still outside, and this is inside the bile duct. So this is the guide wire, and this is sort of, sometimes you can form these sort of pseudo sort of pockets in PSC. We call it pseudo diverticuli, and this is what the inside of your bile ducts can look like. And the ability, if you compare, this is the picture here, this is the cholangioscope up here. So this is the X-ray image, but look at that. That clearly tells you a lot more than looking at a 2D still image. And again, even my kids were quite impressed by this today. Again, I think they think I'm quite nerdy. But you can imagine, and that was a little gush of bile coming back. But being able to look into the bile duct and then target if there is an abnormality improves your yield in terms of improving your sort of diagnostic capability, but also in reassuring yourselves, because your MRI scan can look very sort of, it can be quite diffuse changes. But if we can go in and look and say, actually, it looked okay. There are these little pockets, that's part of the disease, but there's no abnormality in the lining of the bile duct, then that's quite reassuring for yourselves and for us. So a lot of centers now have this technology. It's made by Boston Scientific. There are different toys you can have. So this is to take the biopsy. This is if there's a stone, you can remove it. You can sort of, it's called a basket. And this is a snare. So sometimes stents can sort of migrate up the bile duct and we can pull them back. And if you do have very big stones, we've got this sort of zapping device, which is very sort of satisfying for us, where we can sort of, destroy quite big stones. It's like the Bruce Willis movie, Deep Impact. I always look at everybody, make that comment, and everybody looks at me very weirdly, but there we go. All right. So what about action of the stricture? So here again, you can see there's this is going off to the patient's gallbladder. There's a stricture here. And what we've done here, bit by bit, we've inflated a balloon. And the balloons we use are very small. So we start with a 4mm balloon. So these are sort of tiny balloons, probably go up to maybe 8mm at best. Usually 6mm is the most. And you can see if you stretch it bit by bit, you can make a big difference. And in this case, there's an improvement in the patient's itch, an improvement in the patient's blood tests. And obviously, you can see the direct improvement there. So I've name dropped Doug, and having Doug here is really important because he's been part of some of the seminal sort of work in PSC in the last, I'd say, 5 to 10 years. And this was a study done across Europe in sort of expert centres. Sadly, King's wasn't involved, but I don't think I'd started yet at King's. So anyway, but hopefully we can change that, working with the Royal Free. But what they looked at was, well, should you put a stent in or should you stretch it with a balloon? And the takeaway message of this study, which was stopped early, because actually in patients who are having stenting, they were more likely to develop a sort of complication such as pancreatitis. And this resulted in stretching alone, improvement in itch, improvement in blood tests, improvement in symptoms. So as a group now, we are moving away from putting in stents, and we will try and dilate it, but there will be cases where you still might need a stent. And there's lots of different stents. There's plastic stents, which are straight. There are plastic stents. These are the double pigtails, which look like pigs' tails. And then you have metal stents, and you have sort of stents which you deploy within the duct itself, and you don't need to deliver it into the small bowel. So again, technology is always moving forward. There are biodegradable stents now as well. So these are the Archimedes stent. We're still not quite sure how to use these stents, and they are actually very expensive, but this is just showing how technology is improving as to how we may treat some of these strictures, these narrowings in your bile ducts. One of the problems here, it is very expensive, so I think that's one of the rate limiting steps. So you've had your ERCP, you've maybe had it under general anaesthetic, you can't remember anything, maybe you've had a really good rest, the itching has stopped. So what about your post ERCP care? Immediately, you will obviously look after your monitor your observations, your heart rate, your blood pressure, your temperature. Sometimes after an ERCP, we can sort of increase your risk of cholangitis, and that's why, again, the importance of antibiotics. We'll assess you for pain because unfortunately, even with the best intentions, we might still cause pancreatitis. You will be probably nil by mouth if we stretch things. Again, different places will have different policies on how long you should be nil by mouth for. Usually it's between 2 and 4 hours. But again, making sure that you're well hydrated during this time. And again, antibiotics, antibiotics, antibiotics. So really important. In terms of when you've been discharged, again, different centres will have different ways of monitoring things. They will obviously review your blood tests. The blood test will never resolve completely. If you're jaundiced before, hopefully you'll see a sort of slow decrease in the jaundice level. But if it's not coming down completely, then maybe that's indicative of the liver itself, and maybe it's not just a drainage problem alone. And again, you might be followed up with ultrasound scans, MRI scans, but again, everywhere is very different. So I've described to you the basic anatomy. I've shown you a picture from M&S and how elderflower can look like the bile duct. And it can be very simple. It is, looking at the bile ducts in terms of MRI scanning and then going on to have an ERCP. And like I said, knowing exactly what we are going to do beforehand. And when you meet your consultant or the doctor who's consenting you, you can ask them, well, what is your plan? What are you aiming to do? What is what would be deemed a success of this procedure? So hopefully I've shown you how we do it, why we do it, when, and some of the nuances involved. And it's not just a one-off procedure. It really is about your investigations before, during the case itself, and making sure you're comfortable, whether it's with topping you up with sedation or whether you're having a general anaesthetic, and also your post-ERCP care as well. So I'm going to stop there and I'll happily take questions. Thank you very much.